Teamworking means the difference between the productivity of a team and the sum productivity of the individual members working in isolation, which we call group working. Teamworking is the study of how to maximise this difference. It involves motivating team members and coordinating their strengths, weaknesses and actions. In effective teams, all the members align their personal objectives with those of the team. They fill in for others who lack skills or need help. And they work flexibly between tasks to achieve the agreed objective. Conflicting opinions are to be expected, and the process of resolution enhances the strength of the team. Teamworking takes skill and effort. Without this, we would default to group working. The importance of teamworking to competitive industries and sports has made it the subject of extensive research. This table summarises general differences observed between teams and groups. Teams make decisions by consensus. Groups often don't make decisions at all, expecting them to be made by someone else from outside. Disagreements within teams are resolved. In groups, they tend not to be, and often result in members avoiding each other or hiding their personal feelings. In teams, overall objectives are understood and agreed. In groups, they are not discussed, each member restricting themselves to their own narrow task. Teams communicate much more than groups. All members contribute ideas, and discussions are frequent about what to do, how to do it, and about how well the team is performing. Groups communicate at the minimum level necessary. In teams, leadership is flexible depending on the task. Individual members take the lead in their own areas of expertise and defer to the expertise of other members as appropriate. In groups, this does not happen. The leader is defined by appointment and leads on everything. Following a leader in a direction members know to be foolish is a hallmark of group working. From observations like this, researchers have derived team inventories, scoring systems to measure team working. Healthcare is a large industry, with the UK's NHS being the world's 7th largest employer with 1.4 million workers. Teams and interfaces are often indistinct and constantly changing. Research using team inventories shows that most of the time, NHS staff work as groups rather than teams, an observation that will surprise few. Poor team working is a ubiquitous conclusion of investigations into adverse events. Healthcare is behind other industries in deploying teamwork training. In aviation, spectacular events such as the crash of a passenger plane onto the M1 motorway near Kegworth, the explosion of the Space Shuttle Columbia, and the successful landing of a passenger jet on the Hudson River without loss of life made it a priority. Aviation teamwork training has been developed over 30 years and is now into its 5th generation. The original concept was error avoidance, and while that is a worthy goal, it is an impossible one. Hence, error management became the goal.
Well, in my experience, it came out of aviation, and back in the 1980s and before, there was about one major plane crash a month, which is hard to imagine in this day and age. And eventually it got to such a level that in America, NASA funded some research under Professor Bob Helmreich at the University of Texas in Austin. And Bob and his team went and looked at what flight crew did. So they watched on flight decks, on real aircraft and on simulated aircraft flights to see what it was that effective teams did and what ineffective teams did. And there were some of each. And they narrowed those down into specific behaviors, which was like the origins of really, I suppose, what was anti-pilot error training. And that has since developed into healthcare and nuclear power, ships, running railways, in fact, just about any form of life.
In healthcare, there is growing evidence of benefit from trained team working. All these have been reported: reduction in mortality, reduced error rates, reduced patient time in hospital, which was found to save more money than the cost of training and running the teams, improvement in service provision, enhancement in patient satisfaction, and improved decision-making. Evidence also suggests that effective team working brings benefits to the staff. Doctors in poor teams have nearly twice as much sick leave. Better decision-making, increased motivation and well-being. In one study, 21% of staff in good teams reported above threshold stress levels, compared to 30% of staff in mediocre teams and 35% of staff in groups. Pretty convincing, but the real driver of team working is not that, it's politics. Poor team working always seems to be a major part of the findings of inquiries into healthcare failures.
In an ideal world, you'd avoid everything that could possibly go wrong. And we suggest in healthcare you do this by having effective team meetings beforehand, a briefing before an operating theatre, handover at the start of a ward shift or other area, to share situation awareness, in other words, the plan for the day, and to prepare yourself for what could conceivably go wrong. So nothing totally unrealistic, but say you're doing a laparoscopic surgery, then you might want to be ready for a laparotomy to open up, and you might need to have the kit ready. You might need to have things like blood ready in case you need it, extra blood to compensate for any blood loss. But it's, for me, the effective team is the one that's already got plan B and maybe beyond in place before they start.
The largest public inquiry into medicine in the UK was about the Bristol heart scandal. The death rate following complex paediatric heart operations in Bristol was higher than in other units in the UK. The public inquiry, chaired by Ian Kennedy, ran from October 1998 to July 2001. 900,000 pages of evidence were examined, and oral evidence was taken for 96 days. It found poor performance had been principally due to poor team working. This was Kennedy's assessment. It should be the norm for surgical teams, the surgeon, anaesthetist, theatre nurses and operating assistants, to have time together and with other teams, such as those in the ITU, to review and develop their performance as a team. The scandal had far-reaching consequences. Unlike previous scandals and disasters, there was no single event or individual person behind it. The reason it came to public consciousness was not because of how uniquely bad the situation was, but the coincidence of two other things. A powerful outcome measure. Outcome was number of child deaths, which are easily and objectively measurable and emotive. Whistleblower Dr. Stephen Bolson was an anaesthetist in Bristol who noted the high mortality rate and was prepared to knowingly sacrifice his professional popularity and his job in order to correct the situation. Without these two factors, it is probable that the events in Bristol would have gone on unchallenged. The failings seen in Bristol were, and are, not restricted to that unit at that time. They apply to numerous other units in other specialities that have avoided the coincidence of a powerful outcome measure and a whistleblower.